I still remember the day Mrs. Alvarez walked into my clinic holding a small folded photo of her grandson. She was 68, sharp in so many ways, still baking cookies for neighbors, still volunteering once a week, but she could not remember his name. She told me she took no prescription medications on a daily basis. What she did rely on were a handful of over-the-counter pills she thought were safe. A nightly PM sleep aid, an antacid for heartburn, and a multivitamin with extra B6, because it helps nerves. That ordinary medicine cabinet was quietly working against the one thing she cherished most, her memory. If you're over 60, or you care for someone who is, listen carefully, don't risk it. There are 5 common supplements and over-the-counter medicines that older adults must avoid or at least re-evaluate because they can harm brain health. I will explain what each one is, how it works in the brain, the warning signs to watch for, and the safe next steps you should take, with the goal of protecting memory and independence. I'll also share 3 evidence-backed nutrients that can help instead. Why this matters: aging brings changes in the body that make older adults more vulnerable to medication side effects. The brain loses some reserve, fewer specialized cells, slower repair mechanisms, and the way drugs are absorbed, metabolized, and cleared changes with age. That means a pill that felt harmless at 40 can have outsized effects at 70. What's particularly tricky is that these harms are often silent at first. A person becomes a little foggier, takes a beat to find a word, or starts napping more in the daytime. Those small changes can be misattributed to just getting older, when, in many cases, a medication or a supplement is the cause. We have mounting evidence from long-term population studies and clinical observations showing that certain drugs and supplements are linked with higher risks of cognitive decline and dementia-like symptoms. For example, researchers have repeatedly found associations between regular use of strong anticholinergic drugs and increased dementia risk. Other studies have linked long-term acid-suppressing drugs with vitamin B12 deficiency and neurological problems. Observational studies don't always prove cause and effect, but when a pattern shows up across many cohorts and lines of evidence, it's a red flag worth acting on, carefully and with medical guidance. If you want practical, evidence-based tips for protecting the aging brain, please like this video and subscribe. I'll be sharing straightforward information you can use at home and with your doctor. Number 1. Diphenhydramine and other anticholinergic sleep aids, the one hiding in most medicine cabinets. What it is and where you find it. Diphenhydramine is an antihistamine found in brand names like Benadryl, but it's also the active ingredient in many PM or nighttime sleep aids, products labeled as Nitol, Sominex, or the sleep versions of certain cold medicines. People reach for these because they take effect quickly and seem harmless. They're sold without a prescription and marketed for short-term sleeplessness or allergies. How it harms the brain. Diphenhydramine is strongly anticholinergic. In plain language, it blocks acetylcholine, a neurotransmitter that's essential for forming new memories and for attention. Think of acetylcholine as the brain's sticky note system that helps information stay accessible long enough to be filed. When you block that system, memory formation becomes clumsy. Over weeks and months, regular use increases the brain's anticholinergic burden and is associated in large observational studies with a higher long-term risk of dementia. What to watch for? Early signs often look subtle. Patients describe daytime fogginess, increased sleepiness, trouble finding words, or occasional confusion in familiar places. Family members may notice slower reactions, or that a once reliable person begins to forget appointments or names more often. What to do next? Do not stop prescription medications without medical advice. In the case of diphenhydramine, many people use it as an over-the-counter sleep aid and can safely switch strategies. Safer approaches include improving sleep hygiene, consistent bedtimes, limiting naps, reducing evening screen time, cognitive behavioral therapy for insomnia, if available, and, when appropriate, a short course of melatonin discussed with your clinician. If diphenhydramine is being used regularly, bring it up at your next visit so your clinician can help you taper or find alternatives. Also, check the labels of all over-the-counter products. The ingredient may be listed as diphenhydramine, even when the brand name implies something else. Why this matters clinically? A landmark pattern in research shows that people who regularly take strong anticholinergic medications over years have a significantly higher chance of developing dementia-type symptoms compared to those who do not. Again, that's an association, not a definitive cause and effect statement, but given the availability of safer options for sleep and allergies, and the potentially serious stakes for memory, minimizing exposure makes sense. Number 2, proton pump inhibitors, PPIs, heartburn relief that can starve the brain of B12. What it is and where you find it. PPIs are a class of medications used for acid reflux and heartburn. Common names you may recognize are omeprazole, Prilosec, esomeprazole, Nexium, pantoprazole, Protonix, and lansoprazole, Prevacid. They're prescribed commonly and also available over-the-counter in lower doses. How it harms the brain. PPIs lower stomach acid. That's often exactly what people need to reduce reflux. But stomach acid is also necessary for separating vitamin B12 from the proteins in food, so it can be absorbed later in the small intestine. Over months to years of reduced acid, B12 absorption can drop enough to create deficiency. Vitamin B12 is essential for myelin, the protective coating around nerves, and for many brain processes. When B12 becomes too low, people can develop memory problems, mood changes, gait disturbances, and even peripheral neuropathy, numbness or tingling in hands and feet. What to watch for? B12 deficiency develops slowly and can be easily missed. Signs include fatigue, slow thinking, word-finding trouble, balance problems, tingling or numbness in the fingers and toes, and mood changes. Because symptoms progress gradually, both patients and clinicians can miss the connection to a medication that has been taken comfortably for years. What to do next? Don't stop a prescribed PPI without talking to your clinician. Sudden withdrawal can cause rebound acid production that is unpleasant and sometimes harmful. Instead, ask your provider about whether you still need long-term PPI therapy. If you've been on a PPI for months or years, request a B12 blood test, especially if you also take metformin or have symptoms suggesting deficiency. Your clinician may recommend a trial of stepping down to the lowest effective dose, switching to on-demand therapy, or swapping to alternatives when appropriate. If B12 is low, repletion is straightforward in most cases and often improves symptoms when caught early. Number 3. High-dose vitamin B6, pyridoxine, the nerve vitamin that can harm nerves in excess. What it is and where you find it. Vitamin B6 or pyridoxine is commonly included in multivitamins and marketed in separate supplements aimed at nerve support. Active products may list 50 mg, 100 mg or even higher on the label. Many people assume that because B vitamins are water-soluble, they can't hurt, but B6 is one of the few vitamins with a narrow safety window. How it harms the brain and nerves. At moderately high supplemental doses, typically tens to hundreds of milligrams daily, vitamin B6 can be neurotoxic. The primary reported effect is peripheral neuropathy, damage to the peripheral nerves that causes numbness, tingling, burning sensations, and balance problems. When peripheral nerves are affected, walking and coordination suffer, and some people experience cognitive fog as a secondary symptom. The mechanism is not the same as the B12 deficiency pathway, but the outcome, impaired nerve signaling, can ultimately interfere with brain function and quality of life. What to watch for? Early signs are tingling or numbness, especially in the feet or hands, unusual pins and needle sensations, trouble buttoning a shirt, or a change in balance. Sometimes people complain of a persistent froggy head or less clear thinking. Check your supplement labels. It's surprisingly common to find single-ingredient B6 tablets at 50-100 milligrams per pill, or combination formulas that stack several B vitamins into high totals. What to do next? If you take a separate B6 supplement, review the dose with your clinician. For most adults, a long-term supplemental intake above 25 milligrams daily is unnecessary unless prescribed for a specific deficiency under medical supervision. If you have symptoms of neuropathy, stop high-dose B6 only after discussing with your provider so they can evaluate and monitor for improvement. True neuropathy sometimes takes months to recover even after stopping the offending agent. Also be mindful. Some energy or B-complex products combine B6 with other vitamins, so the total daily intake can add up without you realizing it. A quick reminder about natural labels. Natural and over-the-counter do not equal harmless, especially as we age. The same compound that helps at the right dose can hurt at the wrong dose or when combined with other medicines. Number 4. Statins at high doses in older adults without clear indications. A nuanced risk-benefit balance. Before I go further, I want to acknowledge up front that statins are life-saving drugs for many people. For patients with established cardiovascular disease, those who've had a heart attack or stroke, the protective benefit is clear. The concern I raise here is more specific. Aggressive, high-intensity statin therapy started for primary prevention in very old adults, where the likelihood of benefit is smaller and the sensitivity to side effects is greater. What it is and where you find it. Statins are cholesterol-lowering medications: atorvastatin, Lipitor, simvastatin, Zocor, rosuvastatin, Crestor, among others. They are prescribed widely and in many cases prevent major cardiac events, but cholesterol is also a component of brain structure and synapse function. The brain manufactures much of its own cholesterol for cell membranes and for making and repairing myelin, the insulation around axons. So there is biological plausibility that in some individuals, very low cholesterol levels or aggressive reduction could impact cognition. How it may affect the brain. Some observational reports and clinical anecdotes have described memory complaints temporally related to statin initiation or dose escalation. Proposed mechanisms include alterations in cholesterol-dependent neuronal membranes and signaling. That said, randomized clinical trial data are mixed and overall do not show a large, consistent risk of dementia from statins. In fact, some trials suggest potential cognitive benefits in people with vascular risk. The key is individualization. The balance of benefit versus risk of high-intensity statin therapy may shift with advancing age and in people without prior cardiovascular events. What to watch for? New memory problems or word-finding difficulty that start after a statin is initiated or after a dose is increased. Unexplained fatigue and decreased engagement in mentally demanding activities. If such symptoms appear, they warrant a thorough discussion with the prescribing clinician to weigh cardiovascular risk against cognitive concerns. What to do next? Do not stop statins on your own. Stopping suddenly could increase cardiovascular risk. Instead, bring the conversation to your clinician. Review your overall cardiovascular risk, your goals of care, and whether a dose adjustment, a different statin, or even a monitored trial of lower-intensity therapy is appropriate given your age and comorbidities. In some patients, cognitive symptoms improve after a change in therapy, but results vary. At this point, I usually pause with patients and caregivers to map out priorities. What are the most important health goals? Is preventing a heart attack the main priority, or preserving current thinking and daily function? shared decision-making matters. Number 5, benzodiazepines, long-term sedation that can steal memory. I'm preparing to take a deeper look at benzodiazepines, why they're so risky over the long term, what the evidence says about dementia associations, and how to approach safer alternatives for chronic anxiety and insomnia. But before I do, let me summarize what we've covered so far and make it practical checklist based on what we've discussed up to now. First, do a quick medicine cabinet inventory with me in your head. Don't reach for anything yet, just look. Do you use a nightly PM sleep aid like diphenhydramine? Are you on a daily PPI for heartburn? Do you take a separate vitamin B6 tablet at 50 milligrams or higher? Are you newly on a high-dose statin, or has your statin dose been increased recently? If you answered yes to any of these, you have a starting point for a productive conversation with your clinician. Second, watch for these red flags. Increased daytime sleepiness, word-finding trouble, slow thinking, balance changes, or new numbness and tingling. Those are signals the nervous system is not functioning as it used to and deserve medical review. Third, before making any changes, plan to talk to a clinician. For over-the-counter supplements like high-dose B6, your clinician can advise whether reducing or stopping is reasonable. For prescription drugs like PPIs or statins, a supervised plan is essential. If you have been on a PPI long-term, ask for B12 testing. If you take an anticholinergic regularly, ask about alternatives and sleep behavior strategies. If you're worried about your statin dose, discuss absolute risk reduction in the context of your age and other conditions. The reality is this. Many cognitive harms related to medications are at least partially reversible when the offending exposure is reduced or stopped, especially if caught early. But reversibility is not guaranteed, and recovery can take time. That's why early identification and a thoughtful, clinician-guided plan are so important. What comes next? We've now laid the map for the 5 high-risk items I promised to review. You know why they matter, and you have immediate steps to take for the first 3. Next, I will dive into benzodiazepines in detail, how chronic GABA enhancement affects the hippocampus, what the long-term observational data show about dementia risk, and evidence-based alternatives for anxiety and sleep that are safer for older brains. I will also walk through 3 supplements that have good evidence for supporting brain health: omega-3 fatty acids, magnesium in the right forms, and vitamin B12, including preferred forms and sensible dosing ranges so you can discuss them with your clinician. Before we continue, one last practical tip for what you can do right now. Write down every prescription, over-the-counter med, and supplement you take, including doses. Bring that list to your next appointment. A medication review is one of the most powerful immediate things we can do to protect the aging brain. Editorial corrections for production team, correct spellings and standardized names, diphenhydramine, not diphenhydramine or similar variants, benzodiazepines, not benzoazepines, omeprazole, prilosec, esomeprazole, nexium, pantoprazole, protonix, lansoprazole, prevacid, pyridoxine, vitamin B6, atorvastatin, lipitor, simvastatin, zocor, rosuvastatin, crestor, magnesium glycinate, magnesium L-threonate. Avoid listing magnesium oxide as preferred, vitamin B12 as methylcobalamin, sublingual forms noted for absorption concerns, continuing with benzodiazepines and the positive alternatives in the next section. Now, number 5, benzodiazepines. I want to be very clear about why this class deserves careful attention in anyone over 60, what they are and where you find them. Benzodiazepines include medications such as alprazolam, Xanax, lorazepam, Ativan, diazepam, Valium, and clonazepam, Klonopin. They are prescribed for anxiety, panic attacks, muscle spasms, and short-term insomnia. Because they work quickly, Many people who struggle with anxiety or sleep grab them, and over time continue taking them for months or years. How they affect the brain. Benzodiazepines enhance the activity of GABA, the brain's main inhibitory neurotransmitter. That sounds helpful when anxiety is high or when you need sedation, but chronic enhancement of GABA signaling can blunt the hippocampus, the brain's critical region for forming new memories. Imagine the hippocampus as the part of your brain that takes new information and stamps it into long-term storage. Prolonged GABA overactivity makes the stamp faint. In plain terms, long-term benzodiazepine use is associated with problems making new memories and with slowed thinking. What the evidence shows. Multiple long-term observational studies have found an association between prolonged benzodiazepine use and an increased risk of dementia-type outcomes. Some analyses report relatively large relative risks when use is chronic and begun in midlife or later. These are observational data, associations, not definitive proof of a direct cause, but the consistency across many cohorts and the biological plausibility make this a serious concern, especially when safer long-term alternatives exist for anxiety and insomnia. Warning signs to watch for. Families and caregivers often notice the earliest changes. These may include increasing daytime sleepiness, frequent memory blanks, especially for recent events, new clumsiness or more falls, slowed speech, and a general flattening of alertness. Some people report that they feel foggy in the morning or have trouble following conversations they once navigated easily. Special considerations. Benzodiazepines cause tolerance and dependence. Abruptly stopping them can lead to severe withdrawal symptoms, including rebound anxiety, insomnia, tremor, and, in rare cases, seizures. For people who have been on benzodiazepines for months to years, a supervised plan to reduce or switch medications is crucial. Also, when benzodiazepines are combined with other sedating substances, especially alcohol or opioid pain medications, the risk of dangerous sedation and falls rises dramatically. What to do next? Do not stop benzodiazepines on your own. If you or a loved one are using a benzodiazepine regularly, make an appointment to talk with the prescribing clinician. A careful, clinician-supervised plan can assess whether the drug is still needed, whether alternatives might be safer, and how to reduce use with as little risk as possible. For some people with severe treatment-resistant anxiety or certain seizure disorders, benzodiazepines remain necessary. This is why individual decision-making matters. For many older adults, however, evidence-based alternatives exist that are safer for long-term use. Safer alternatives and strategies for insomnia and anxiety. There are several evidence-based approaches that clinicians discuss with older adults. Cognitive behavioral therapy for insomnia, CBTI, and cognitive behavioral therapy for anxiety are effective and carry no sedating drug burden. Mindfulness-based stress reduction, paced breathing, and structured sleep routines also help. When medication is necessary for chronic anxiety, some antidepressants, selective serotonin reuptake inhibitors, SSRIs, or serotonin norepinephrine reuptake inhibitors, SNRIs, may be considered as alternatives under medical guidance. These have their own side effect profiles and need individualized assessment. Short-term use of sleep aids may sometimes be appropriate, but rely on clinician judgment. The key is deliberate, monitored substitution rather than abrupt cessation. A final clinical note about benzodiazepines. If someone has been taking these drugs for a long time and is showing cognitive decline, a coordinated medication review with a primary care clinician or geriatrician and a pharmacist can be life-changing. Many patients experience measurable improvements in alertness and memory after benzodiazepines are reduced or stopped under supervision, but recovery varies and may take months. Because of the risks of withdrawal, tapering should always be guided by a clinician. Now that I've walked through the 5 high-risk items, let's shift to the positive. 3 supplements with better evidence to support brain health when used appropriately. Omega-3 fatty acids, magnesium in specific forms, and vitamin B12. These aren't magic bullets, but they are tools that can support brain function when combined with good medical care and a healthy lifestyle. Omega-3 fatty acids, DHA and EPA, why they matter and how to use them safely. Role in the brain. Omega-3s, especially DHA, are structural components of neuronal membranes and support synaptic function and anti-inflammatory pathways. EPA contributes to vascular and inflammatory balance, which indirectly supports brain health. Together, they help maintain cell membrane fluidity, support healthy signaling between neurons, and can reduce low-grade inflammation that contributes to age-related cognitive decline. Preferred forms and product quality. Look for products that list combined DHA and EPA amounts, and that use molecularly distilled or otherwise purified fish oil to reduce contaminants. For those who avoid fish, algae-derived DHA supplements provide a vegetarian alternative and can deliver meaningful DHA without fish sources. Third-party quality testing, USP, NSF, or similar, is a reasonable filter for product selection. Typical dosing and precautions. For generally supporting brain health in older adults, combined DHA-PSEPA dosing in the range of about 1,000 to 2,000 millimers per day is commonly used in studies and in clinical practice. That range is a typical guideline. Individual needs vary. A crucial caution: if you take blood thinners, including warfarin or certain direct oral anticoagulants, talk with your clinician before starting a high-dose omega-3 supplement because of a potential, though generally modest, effect on bleeding risk and interactions. Also discuss omega-3s if you're planning a surgical procedure. What to watch for? Mild gastrointestinal symptoms are the most common side effects. Rarer issues include fishy aftertaste or, in very high doses, a theoretical increase in bleeding risk. As always, discuss with your clinician and document the supplement on your medication list. Magnesium, choosing the right form for sleep and cognition. Why magnesium matters. Magnesium is involved in hundreds of enzyme reactions in the body and plays a role in neuronal excitability, synaptic plasticity, and sleep regulation. It's a general nervous system modulator that can support relaxation and may improve sleep quality and some aspects of cognitive function. Preferred forms. Not all magnesium supplements are alike. Magnesium glycinate, magnesium bound to glycine, is well tolerated and often used when the goal is improved sleep or reduced muscle tension. Magnesium L-threonate has drawn interest because some animal and early human data suggest it may more readily cross the blood-brain barrier and support memory and cognitive function. It's the form often discussed specifically for cognitive support. Magnesium oxide is inexpensive but poorly absorbed and often causes diarrhea. It's generally not the best choice for brain-focused supplementation. Typical dosing and precautions. For many older adults, a supplemental elemental magnesium dose of roughly 200–400 milligrams per day is reasonable, depending on diet and kidney function. Kidney disease can make magnesium supplementation risky, because the kidneys excrete magnesium. If you have kidney impairment, discuss dosing with your clinician. Magnesium can interact with certain medications, including some antibiotics and diuretics, so include it on your medication list for review. What to watch for? Excess magnesium from supplements can cause loose stools, or, at very high doses in susceptible people, more serious symptoms. If you have persistent gastrointestinal upset after starting magnesium, tell your clinician or pharmacist. Vitamin B12, methylcobalamin. Prevention and correction of deficiency. Why it's critical. Vitamin B12 is essential for maintaining myelin and for normal neuronal metabolism. Low B12 levels are a reversible cause of memory problems, mood changes, and gait disturbances, and older adults are at particular risk because absorption declines with age, and medications like proton pump inhibitors and metformin can further impair uptake. Preferred forms and testing. Methylcobalamin is a bioavailable form, often favored clinically, and sublingual formulations can bypass some aspects of gastrointestinal absorption, which is useful for people with impaired stomach acid. In cases of severe deficiency or absorption failure, clinicians may recommend intramuscular injections. Blood testing should include at least a serum B12 level, and when results are borderline, methylmalonic acid, MMA, or homocysteine can help clarify true deficiency. Typical dosing and precautions. For adults with absorption concerns or documented deficiency, oral supplemental doses of 500 to 1,000 mcg micrograms daily are commonly used, though exact regimens depend on the clinical situation. When B12 is normal, routine low-dose supplementation as part of a balanced diet is reasonable. Because B12 is water-soluble and generally well-tolerated, side effects are uncommon, but discuss dosing with your clinician, especially if you have complex medical conditions. What to watch for? Signs of B12 deficiency include persistent fatigue, slow thinking, numbness or tingling in hands and feet, balance problems, and mood changes. If you have any of those symptoms and are on a PPI or metformin, request testing. Putting it together, an actionable checklist you can use today. You've now heard the 5 things to avoid or reassess and the 3 supportive nutrients to consider. Here are concrete steps you can take right away, phrased as actions you can bring to a clinician visit. 1. Inventory everything you take. Write down every prescription, over-the-counter medication, and supplement, including doses, and how often you use them. Include products you take as needed. Bring that list to your next appointment. 2. Watch for the red flags. Note any new or worsening daytime sleepiness, word-finding trouble, slower thinking, balance changes, or new numbness, tingling. These are signals that deserve medical review. 3. Ask for a medication review. Specifically ask your clinician or pharmacist to evaluate anticholinergic burden, long-term benzodiazepine use, high-dose B6 content, chronic PPI therapy, and whether your statin intensity matches your current cardiovascular goals. Pharmacist-led deprescribing programs can be very helpful. 4. Request targeted testing when indicated. If you've used a PPI for months or years, ask about serum B12 testing. If neuropathy symptoms appear and you take high-dose B6, discuss stopping or reducing B6 under supervision and request neurological evaluation. If you have cognitive concerns, a basic cognitive screen and review of reversible causes, vitamins, thyroid, sleep apnea screening, depression, is reasonable. 5. Discuss alternatives rather than abrupt stopping. For benzodiazepines, PPIs, and statins, insist on a clinician-supervised plan if changes are needed. For OTC anticholinergic sleep aids, consider behavioral sleep strategies and discuss short-term melatonin with your clinician as an interim measure. 6. If you choose supplements for brain support, pick evidence-backed forms and tell your clinician. For omega-3s, choose products with combined DHA, EPA in the $1,000–2,000 mg/day range and ensure product quality. For magnesium, prefer glycinate or L-threonate and avoid magnesium oxide for cognitive goals. For B12, methylcobalamin is appropriate and consider sublingual forms when absorption is a concern. Lifestyle pillars that make the medicines and supplements work better. Supplements and medication adjustments are part of the story, but the foundation of brain health is lifestyle. These are practical, low-risk interventions that work in combination and that you can start today. Sleep. Prioritize consistent sleep schedule, avoid late-night heavy meals and alcohol, limit caffeine after midday, and create a calm bedtime routine. If insomnia persists, ask about CBTI, an evidence-based therapy that reshapes habits and thoughts around sleep without sedating drugs. Movement. Aim for regular physical activity. Aerobic exercise supports blood flow to the brain. Resistance training helps maintain muscle mass and metabolic health. Even steady walking, garden work, or short home routines are beneficial. Exercise also improves mood and sleep. Social engagement and cognitive stimulation. Maintain social connections and mentally stimulating activities. Reading, games, discussion groups, learning a new skill, or volunteering. These activities increase cognitive reserve and can slow functional decline. Nutrition and hydration. Favor a Mediterranean-style eating pattern rich in vegetables, fruits, whole grains, legumes, fish, and healthy fats. Maintain regular hydration. Even mild dehydration can blunt cognition and energy. Vascular risk control. High blood pressure, uncontrolled diabetes, high cholesterol, and smoking all increase risk for cognitive decline. Work with your clinician to manage these risks in a way that respects your overall goals and tolerances. Sensory health and mobility. Manage hearing and vision problems promptly because untreated sensory loss isolates people socially and can worsen cognitive strain. Regular vision and hearing checks are important in sustaining engagement and safety. When to seek urgent help. If someone develops sudden worsening confusion, a sudden focal neurologic deficit, weakness, slurred speech, sudden vision change, new severe balance loss, or symptoms suggesting severe withdrawal from benzodiazepines, seizures, severe agitation, those are medical emergencies and need immediate attention. For gradual or subtle changes, schedule a prompt appointment with your clinician to review medications and reversible causes. What recovery looks like. Realistic hope without guarantees. One of the most important things I tell patients is that action matters. When a medication that impairs cognition or a supplement at an unsafe dose is identified and managed, many people show improvement in alertness, memory, and daily functioning. The pace and extent of recovery vary. Peripheral neuropathy from B6 toxicity can take months to improve and sometimes leaves residual symptoms. Cognitive gains after stopping a benzodiazepine or reducing anticholinergic burden often improve over weeks to months, but full recovery isn't guaranteed. Vitamin B12 deficiency, when detected early, often responds well to replacement. The takeaway: early detection and a careful, clinician-guided plan give you the best chance for meaningful improvement. Putting it into practice, a suggested script for your clinic visit. When you sit down with your clinician, consider using a short script to make the visit focused and productive. For example, I've made a list of everything I take, and I'm concerned about how some of these might be affecting my memory and balance. Could we review my anticholinergic medicines, my PPIUs, my vitamin B6 supplement, my statin dose, and whether my benzodiazepine is still needed? Also, can we check my B12 level? That covers the high-risk items succinctly and invites shared decision-making. Common questions I hear and brief answers. Boom, my parent has been on a PPI for years. Should they stop it? Not without talking to their clinician. Ask whether long-term PPI therapy is still necessary and request B12 testing. There are often step-down strategies or alternatives a clinician can consider. I took Benadryl for sleep for years. Can I just stop? Don't stop all at once if you're dependent on it for sleep. Many people can switch to non-sedating strategies and reduce use safely with a clinician's guidance. For many folks, stopping regular diphenhydramine improves daytime alertness and memory. Is it safe to take omega-3s with my blood thinner? Discuss with your clinician. Often it's safe at modest doses, but dose and individual bleeding risk matter. Dime, my doctor told me to take high-dose B6 for nerve pain. High-dose B6 for certain neuropathies is sometimes used short-term, but long-term daily doses above 25 milligrams without medical indication are generally unnecessary and potentially harmful. Revisit this with the prescribing clinician and request follow-up if symptoms change. A closing reassurance. I know this information can feel overwhelming. The intention here is not to frighten, but to empower. Many people assume that anything labeled natural or sold over the counter must be harmless. That's not always true, especially as our bodies change with age. The good news is that a thoughtful medication and supplement review, guided by your clinician and pharmacist, is one of the most powerful steps you can take to protect thinking and independence. You don't need to make decisions alone. Ask for a medication review, bring a family member if helpful, and take one action this week. Write down every pill and supplement you take and bring that list to your next appointment. Final practical recap in one paragraph. Don't risk it. Check your medicine cabinet for diphenhydramine-containing sleep aids and other anticholinergics. Reassess long-term PPI use and get B12 tested if you've used them for months or years. Avoid chronic high-dose vitamin B6 supplements. Discuss the intensity of statin therapy with your clinician in the context of your cardiovascular risk and goals. And never stop benzodiazepines on your own. Work with a clinician to reduce or replace them safely. At the same time, consider evidence-backed supports like omega-3s, DHA, EPA, magnesium glycinate or magnesium L-threonate, and methylcobalamin B12 when appropriate and under medical guidance, and invest in sleep, movement, social connection, and vascular risk control. If this helped, please share it with someone who checks their medicine cabinet and tell me where you're watching from and which item surprised you most in the comments below. Subscribe for more practical, evidence-based brain health guidance for older adults and caregivers. Above all, take that list to your next clinician visit. Protecting memory and independence often begins with one informed conversation. Closing note from me to you. I've seen patients regain clarity and confidence after small, careful changes. Be curious, not fearful. With the right team and a plan, you can reduce avoidable risks and give your brain the best chance to stay sharp. End of script.